Hello all. Welcome to the second session on vertical integration topic. Today, in the last class, we selected anemia, and today we have a different topic, and that's what we are going to discuss is thyroid. Regarding thyroid, we'll have faculties from Department of Medicine representing by Dr. Renoy, who is additional professor in the Department of General Medicine, and we have Dr. Sidhu representing from the Department of General Surgery, he is assistant professor, and Dr. Dimple from the Department of Anatomy, she is the assistant professor there, and Dr. Rose from the Department of Physiology, who is associate professor. So we have got an very good panel here. I'll be going through certain questions to them, and we'll try to be as interactive as possible, and we'll go through the anatomy, the physiology, and basic clinical features of thyroid-related diseases. And to conclude, what is the final answer, that is the surgeon, whether we require surgery or not, that will be your take. So, with this in mind, I'll asking to start with Dr. Dimple. Can you just briefly give an overview about the thyroid gland?
Thank you for the brief introduction. The thyroid gland is a highly vascular butterfly-shaped gland which is situated in the front of the neck at the level of the trachea, between the 5th, 6th and 7th cervical vertebra up until the 1st thoracic vertebrae. It is a head-shaped gland and it has two lobes. The two lobes are connected in the central part of the neck at the level of the 2nd to 4th tracheal rings by the intervening isthmus. Now, the thyroid gland is an encapsulated gland. So it has two different capsules. That's the true capsule and the false capsule. The true capsule is actually a fibrous condensation of the stroma of the gland itself. So it is true to the thyroid gland. Whereas the false capsule is due to the splitting up of the pretracheal fascia, as the fascia of the neck. So that's the two different capsules. Now, modification of this false capsule is called as the Berry's ligament of the thyroid gland, which attaches itself to the cricoid. So, such an anatomical attachment of the thyroid to the cricoid because of this ligament of Berry is the basis for which the thyroid gland moves with deglutition. So, that has to be kept in mind. Okay. Now, coming to the morphology of the thyroid, the external features, it has, as I said, it has two lobes, and it has, each lobe has apex, base, and three surfaces. That's the superficial surface, the deep surface, and the medial surface. These surfaces separated by the anterior border, which is sharp, and the posterior border, which is more blunt. And the intervening isthmus, it lies between the 2nd to 4th tracheal rings. And this isthmus also has a anterior surface, posterior surface, and a superior and inferior border. So, to briefly explain the extent of the thyroid gland, the apex extends up to the oblique line of the thyroid cartilage, whereas the base, it extends up to the 5th to 6th tracheal rings. But the isthmus is not so. It falls a little short. So it lies between the 2nd to 4th tracheal rings. So this is the brief introduction.
Can you just give me the blood supply, if anything, specific to thyroid? Because we have a surgeon right now here, so they will be very much knowing about the blood supply.
Yes. So the thyroid gland is supplied by mainly two arterial supply, the superior thyroid and the inferior thyroid artery. Okay. The superior thyroid artery is a branch of the external carotid, a direct branch of the external carotid artery, and it reaches up till the apex of the thyroid gland, and it divides into anterior and posterior branches. This superior thyroid artery, it is also accompanied by a nerve, which is the external laryngeal nerve. Okay. So this anatomical relation of the artery with the nerve in relation to the apex is of extreme clinical importance in respect to the surgeons. Sure. Okay. That I think sir will say.
We'll definitely
coming to the other artery, that's the inferior thyroid artery. Okay. The inferior thyroid artery is a branch of the thyrocervical trunk that also supplies the thyroid gland. Sometimes in 30% of the cases, according to our literature, there is an aberrant artery, which is the thyroidea ima artery, which
question I was about to ask.
supplies the isthmus of the thyroid gland.
Okay, because the only thing that I remember from the blood supply is the thyroid in my artery when I was learning. So that's the difference. Okay, fine. So one more just quick question is that what all questions they can expect from anatomy, the students, like an essay question, what all they can expect from anatomy regarding thyroid?
The main, it is usually a very
Okay.
expected question. So the external features, the
Okay.
relations of the lobes
Okay.
and the isthmus, because there is a lot of important relations of the gland to the other surrounding structures.
Okay.
The knowledge of which is extremely important during surgical interventions.
Okay.
And also the blood supply of the thyroid gland is
Okay.
of extreme importance.
They should know the diagrammatic
Definitely.
representation.
Yes, and also the microscopic features of the thyroid gland is also important.
Okay. Thank you. Thank you, Dr.
Thank you.
Dimple, for that elaborative discussion. And next, we'll go to the physiology one. And Dr. Rose, can you just briefly tell us the different hormones produced from the gland and its regulation?
So coming to the main two functions of the thyroid gland, that is, one is to secrete the thyroid hormones, which
Okay.
maintain the metabolism in the tissues.
Okay.
And the second is to secrete calcitonin by the
Okay.
parafollicular or the C cells of the thyroid gland.
Okay.
So coming to the various thyroid hormones, we have T3, T4 and reverse T3.
Okay.
So this T4, it is also called thyroxine
Okay.
or tetraiodothyronine, and
Okay.
this forms 90% of the thyroid output.
Okay.
Then we have T3 or triiodothyronine, which forms 10% of the thyroid output. Then we have the reverse T3 or RT3, which is biologically inactive, and it forms less than 1% of the thyroid
Okay.
output. So when you compare T4 with T3, the T3 is more biologically active
Okay.
than T4.
Okay.
And this T3 is generated at the site of the action by the deiodination of T4.
Okay.
Now coming how it is regulated, the secretion of thyroid hormone. Actually that is through the hypothalamo-hypophyseal and thyroid axis.
Okay.
Okay, so from the hypothalamus actually TRH or the thyrotropin releasing hormone is released.
Okay.
And this TRH release actually it is controlled by nervous stimuli like emotion, stress, exposure to cold, etc.
Okay.
And this TRH that is released from the hypothalamus, it will go and stimulate the anterior pituitary or the adenohypophysis
Okay.
to release the thyroid stimulating hormone, or
Okay.
it is also called thyrotropin.
Okay.
Okay, and this TSH, it will go and stimulate the thyroid gland to secrete various thyroid hormones.
Okay.
So whenever there is an increase in thyroid hormone, it inhibits TRH from the hypothalamus as well as TSH from the anterior pituitary, and this inhibition is more by T3
Okay.
and to a lesser extent by T4.
Okay.
So this is about the hormonal and the
And what is,
regulation.
when we do the investigation, I have always been writing free T3, free T4. Can you, what is this free T3, free T4? That's in the circulation, that's what I think.
Yeah, free T3 is in
It's
the
circulation. Fine. So the T3 and T4, when we assess, when we ask for the investigation, we usually ask free T3. That I'll, maybe we can discuss that. Okay. So again, questions that they can expect from this area.
Actually, as far as physiology is concerned, this thyroid gland is an essay for them.
Okay.
Name the thyroid hormones,
Okay.
then about the synthesis and secretion and
Okay. Okay.
storage and secretion of thyroid hormone, then
Oh.
about the physiological actions or the
Okay.
functions of thyroid gland.
Okay.
So that is a very important expected
It's a very
essay.
expected essay for them. Okay. With that in background, we'll come to Dr. Rina. Can you just briefly tell us regarding the common disorders associated with thyroid gland?
Yeah, I think this will be a continuation from what has been already mentioned, because I think situations where actually the thyroid hormone is in excess, which can again further be subdivided into primary, which is actually affecting the thyroid gland per se, and secondary causes.
Okay.
The primary causes where actually it is in excess would be, the most common one is the Graves' disease, or an MNG, that is a multinodular goiter, which is actually hypersecreting, or a toxic single nodule or a solitary adenoma. These are the common things that are there. But nowadays we see a lot of thyroiditis in picture, where actually there is destruction of the thyroid gland after a viral infection, like a subacute decurrence like viral thyroiditis, or even sometimes postpartum cases where there is a significant thyroiditis. So these are the important things which usually causes the problems in the thyroid. But having said that, iatrogenic causes cannot be completely ruled out, because iatrogenic causes where actually you give radio frequency ablations as well as other therapies which can affect the thyroid gland can also cause hypersecretion also. Lithium, amiodarone and other drugs which can also be actually given, which also causes both hyper as well as hypothyroidism. Hypothyroidism is also quite commonly seen. And obviously the other malignancies which can also cause increasing thyroid functions or hypersecretions. The secondary one in hormonal excess would be because of some TSH secreting tumors per se. Now coming to the next division, that is hormone deficiency, that is actually classically presenting as hypothyroidism. Hypothyroidism, the most common again would be an autoimmune like Hashimoto's thyroiditis. Iodine deficiency can be actually seen in probably mountainous areas and things like that, which definitely with iodized salts and other things, it is definitely significantly come down. The other things which are important is actually the hypothyroid phase of the thyroiditis per se. Okay, patients can go through a hyperthyroid phase, then euthyroid, and most of these people actually end up into a hypothyroid phase. Then again, whenever you think of this one, I think iatrogenic causes also have to be looked at. Iodine therapy, thyroidectomy, or any anti-thyroid drugs in excess can also cause this particular problem. Whereas secondary causes, definitely I think again the most important thing is the pituitary, panhypopituitarism can also cause be a secondary cause of hypothyroidism. The other thing is actually which predominantly comes into his branch, which is actually a nodule or a tumor that is there in the thyroid. This is one of the common presentations to the hospital. They actually come to the doctor saying that there is a thyroid nodule, which could be probably non-functioning. It could be because of multiple reasons actually, some of which comes into hyper and hypothyroidism as well. Some of them like lymphomas or certain other malignancies which need not be always functional. So this is a brief overview of different types of thyroid disorders which present.
And just one more question, sir. Do you think stress has got any role in creating hypo and hypothyroidism? Because when we look into the physiological aspects, definitely the stress response, definitely there is going to be an increase in hormone production. Because now recently when I was studying, during that time and all, we were thinking that hypothyroidism is causing the stress to the patient rather than stress causing hypothyroidism. Is that what we need to think? Because right now we are seeing a lot of hyper. Previously we used to see a lot of hypo.
No, stress probably, I mean, I'm not sure exactly, but one thing that is very classically described is the sick euthyroid syndrome, so where actually non-thyroidal illness or especially critical kind of illness, which is stress being one of the factors, definitely, among the other factors that are there, can produce certain abnormalities in the thyroid functions, okay? And that, I think, probably will answer partially your question, but pure stress in the form of like stress happening in your life and things like that, whether it will affect the thyroid is something I cannot concretely say about.
No tool as such to evaluate
assess that also. Yeah.
Okay. So Sidhu, the next thing is that we see a lot of patients with neck swelling. Next thing that we call is that show to a surgeon. So a patient has come to you with a neck swelling. So how will you approach a thyroid swelling or a neck swelling to do? I will be more precise, maybe a thyroid swelling. Yeah.
So thyroid swelling, first itself assessment of a thyroid swelling will be starting with the age, because different age group patients will be having different type of thyroid swellings. Then we'll see for the place where the patient is coming from, whether the patient is coming from an endemic area for goiter or a non-endemic area. So these are the important things, and of course the sex of the patient. Female patients are more prone to get thyroid disorders when compared to male patients. So these are the things which we ask in the biodata of the patient. And coming to the chief complaint, almost always 90% of patients will be coming with a neck swelling. So the main chief complaint will be the swelling in front of the neck. Some others may have associated pain also. So again, history of present illness, we'll be asking the details of the swelling. When the swelling was first noticed, especially in case of thyroid swelling, it will be first seen rather than felt first. So when the thyroid swelling was first seen, whether it was noticed by the patient relatives or whether the patient saw it while looking into the mirror. Such things we'll ask. Then whether the swelling is gradually increasing in size or rapidly increasing in size, whether there is any associated swellings other than the swelling which is noticed in the thyroid region. So all these regarding the swelling we'll be asking in the history. Second, this is regarding the first heading, the swelling heading which we'll be asking. Second, we'll ask for features of hyper or hypothyroidism, which we'll be discussing later. Then third, we'll be asking for any features of primary or secondary thyrotoxicosis. Again, that I think we'll be discussing. Fourth, broad heading will be any features of compression symptoms, because this thyroid swelling, when it increases in size, it will be compressing the structures underneath, which will be the trachea, the esophagus and the recurrent laryngeal nerve, which can cause dyspnea, dysphagia, hoarseness of voice. So fourth broad heading will be the compression symptoms, and the fifth broad heading will be to rule out history, which we'll be asking to rule out malignancy. Mostly thyroid malignancies, papillary carcinoma will be metastasizing to the surrounding lymph nodes, cervical lymph nodes. So we'll be asking history of any other swelling which the patient has noticed in the neck. Second history will be any skull or any flat bone swellings, because follicular carcinoma will be metastasizing to flat bones. And we'll be asking for any hemoptysis or cough for any lung metastasis or any jaundice for liver metastasis. So this finishes the chief complaint and the history of present illness. And now we'll be asking for past history, which most important will be any history of irradiation in the past, because that is very prone for developing papillary carcinoma of thyroid. Then other personal history, like whether the patient is taking any diet which is rich in brassica family, like cabbage, vegetables and all. So that is also important. Then coming to drug history, already Renoy sir had discussed a few drugs, any anti-thyroid drugs like lithium, amiodarone, which interacts with the thyroid hormone production. So such history we'll be asking in detail in a case of thyroid swelling. And of course, one more thing, sir, family history, because medullary carcinoma of thyroid, which is associated with Men's syndrome, can run in the family, and it can present as a congenital thyroid swelling, which is of importance.
Okay. So my question is that in 16-year-old girl has come to your OPD and she's telling that she's having some neck swelling. So how will you have asked this history? So examination per se of the swelling, how will you proceed?
So this is only regarding the history part which I have discussed so far. Now we want to do a clinical examination. So after taking this brief history, we'll be proceeding with the clinical examination. If the patient is a normal built patient with a thyroid swelling, we'll be inspecting the patient with a neck slightly extended, sitting in front of the patient. We'll be seeing for inspection. Then there is a named method for inspection, which is the Pisilos method, wherein we use this method only for short neck patients and for obese patient, wherein we clasp the fingers, keep it in the occiput and tell the patient to extend the neck, so that the cervical vertebra will be pushing the thyroid gland forward, so that on inspection we will be seeing the gland much clearer. So normal patients, we'll discuss about normal patients. So with neck slightly extended, we'll see for the thyroid gland, we'll see how the swelling is, whether it is on the left side, right side or central, wherever it is. We'll see the extent of the thyroid swelling, where it is extending. We'll see for the lower border of the thyroid swelling. And the main thing, as ma'am had already discussed, we see whether the swelling is moving with deglutition or not, because there are very few swellings in the neck which moves with deglutition, and thyroid swelling is one of the most common swelling which moves with deglutition. This is regarding the inspection. We see for any scars, any sinuses or any other any routine things which we discuss in the swelling chapter itself. Then we'll come to the palpation aspect. Palpation, we'll usually normal thyroid patients we'll palpate standing from behind, and we'll not ask the patient to extend the neck, rather than slightly flexed. We'll start palpating from behind the patient. We'll be using the 4 fingers on each lobe. We'll be palpating, and we'll be seeing for any palpable nodules. If the gland is what the extent of the gland is, then we'll be seeing for the lower border whether it is palpable or not. Because on inspection, if we are not seeing the lower border, then we should be doing the Pemberton's test to see for any retrosternal extension, because that is of surgical importance. So in palpation, we'll be confirming the retrosternal extension by going and seeing the lower border of the thyroid, whether it is palpable or not. Then we'll see for the position of the trachea, where the trachea, if it is a one side enlarged nodule, it will be pushing the trachea to the opposite side, which may cause a sign called the trail sign, that is prominence of the head of sternocleidomastoid. So that can also be seen. That is about palpation, and of course we'll be palpating the other neck swellings, any other lymph node which is present or not. Then we'll proceed with the percussion. Percussion we usually do on the manubrium sterni to see for any retrosternal extension. If it is, usually it is resonant note. If it is a dull note, then we can suspect a retrosternal extension. Then last, we'll auscultate for the thyroid bruit. Especially, we'll be auscultating on the superior thyroid artery, because it is a direct branch, as ma'am was telling. It is a direct branch from the external carotid artery, and about 80% of the blood supply of the thyroid will be coming from the superior thyroid artery. That is the reason why we are auscultating on the superior pole for the superior thyroid artery bruit.
Thank you, Sindhu. So the questions I think I will ask you least, because we have a lot of other things from this, because anatomy physiology we have started. Dr. Dimple, can you just briefly describe the histology of the thyroid gland? So as you said, the histology is the most important question.
Yeah. The histology of the thyroid gland, as I said earlier, the thyroid gland is encapsulated, has a capsule. So the capsule of the thyroid gland sends in septa into the parenchyma of the thyroid gland, thereby dividing the parenchyma into lobules.
Okay.
So within each lobule, there will be presence of 40 to 50 follicles, thyroid follicles. So the follicles, each follicle, as per when we take, the follicles are lined by cells, and in the center of the follicle there is a space wherein there is accumulation of colloid. So the shape of the follicular cells varies based on the activity of the thyroid gland. So so based on the activity, we divide or see the follicular cells in different shapes. So if it's an inactive thyroid gland, then the colloid which is present in the center is abundant. So this colloid pushes the cells towards the periphery. So thereby the follicular cells have a more flattened appearance, they are more squamous. This is an inactive thyroid, inactive stage. In the moderately active stage, the colloid is moderate in amount, so thereby the follicular cells assume a cuboidal shape, so they are cuboidal cells. In a highly active stage, the colloid is very minimum, so because of that, the follicular cells have tall columnar cell appearance. So based on the activity of the cell, it changes.
Histology changes.
The histology changes. And in not only the follicular cells, we do see also C cells. They are also called as clear cells. They are polyhedral cells and they are highly eosinophilic cells. These cells can be seen between the basement membrane of the follicle and with that of the cell, or between two different follicles. So all these slides are usually stained by H&E staining, the hematoxylin and eosin staining.
And they need to draw this for your exam?
Definitely, they'll have to draw this. A very commonly asked question. Histology of the thyroid gland. It's a very simple question if it's been asked. Easy to draw.
Okay. Thank you, Dr. Now I'll to Dr. Rose. Can you just briefly tell regarding the synthesis and storage of the thyroid hormones? Yeah.
So, as you know, iodine actually it is very essential for the synthesis of thyroid hormone. And we ingest the iodine in the form of iodides. And 95% of the total body iodine is present in the thyroid gland. That is 5% in the follicular cells and 90% in the colloid as part of thyroglobulin. So coming to the steps in the synthesis and storage of thyroid hormone, we have mainly 6 steps. So first is iodide trapping. Second is the synthesis and secretion of thyroglobulin. Third is oxidation of the trapped iodine. Then fourth is the organification of thyroglobulin. Then fifth, coupling reaction. And finally, the hormone that is being synthesized is stored. So since the synthesis and secretion and the storage is usually asked as a essay or a short note. So in the synthesis, I told you there are 6 steps. So let's discuss each step a little bit in detail. So first is iodide trapping. So what I told is what we ingest is in the form of iodides. And this iodides from the bloodstream, it will enter the thyroid follicular cells through a symporter called the sodium iodide symporter.
Okay.
And this symporter, it is present in the basolateral membrane of the thyroid follicular cell.
Okay.
So 2 sodium and 1 iodide, it will enter the thyroid follicular cell from the blood.
Okay.
And actually it is against the chemical and electrical gradient, and this is a secondary active transport mechanism.
Okay.
So actually the thyroid stimulating hormone controls this reaction, whereas the antithyroid agents like the perchlorides and thiocyaninates, they will inhibit this iodide uptake.
Okay.
Then coming to the second step, that is the synthesis and secretion of thyroglobulin. Actually this thyroglobulin is a large glycoprotein molecule, and it is made up of about 123 tyrosine residues.
Okay.
And this tyrosine residues, it acts as a substrate for iodine for the synthesis of thyroid hormone.
Okay.
Now coming to the third step, that is oxidation of iodide, that is the iodide that is being trapped inside the follicular cell, that enters the lumen of the follicle
Okay.
through the through a exchanger called the chloride iodide exchanger that is present in the apical membrane.
Okay.
So the iodide, it will penetrate the apical membrane and it will reach the colloid.
Okay.
So this chloride iodide exchange is also called pendrin.
Okay.
And near the apical membrane, there is an enzyme called thyroid peroxidase.
Okay.
And this thyroid peroxidase will oxidize the iodide to iodine.
Okay.
And thyroid is the only tissue that can oxidize iodide to iodine.
Okay. Okay.
So iodide is formed. Now the fourth step is the organification of thyroglobulin.
Okay.
So here there is iodination of these tyrosine residues, and their forms, the tyrosine residues are iodinated to form MIT and DIT. MIT is monoiodotyrosine and DIT is diiodotyrosine. So in the coupling, the next step is coupling reaction. In the coupling, 2 molecules of DIT will combine to form the thyroxine or T4.
Okay.
Whereas 1 molecule of MIT and 1 molecule of DIT will combine to form T3.
3.
So that is the 5th step, and finally the hormones that is being formed is being stored in the colloid
Okay.
for the future requirements. And this can be utilized for about 1 to 3 months. This will be the body's requirement.
Okay. Okay. Fine. So this is the one of the most
Important
common
and
expected questions for the
question.
students. Yes. Thank you. Thank you. Then now to Dr. Nanai, and can you just briefly tell the common blood investigations that we need to do when we have a patient with a suspected thyroid disorder? Because we'll come to symptoms and signs later. Because this has got
this is a continuation.
Of the same.
So, as a part of a continuation of what Madam has said, I think the most common blood investigations that we do are actually the TSH, the T3 and T4. I mean, most of the laboratories have a total T3 and T4. I'm just adding on to what you earlier said. And what is actually done on a routine, probably, especially when you do a screening test or when you are in a comprehensive analysis and stuff like that, it's better as a screening you do a TSH along with a free T4 as well as an anti-TPO.
Okay.
I'll tell you why it is important. So the usual pattern is actually whenever there is a decrease in TSH, and if there is an increase in the thyroid hormones, we are thinking of something called as hyperthyroidism or thyrotoxic spectrum. Whereas when you have a TSH being high and the thyroid hormones being low, then you are considering what is called as a hypothyroidism. Now again, why this free T4? Because you know that the other one is actually bound. So the basic concept is free circulating one is actually more easy to actually assess, and the fact that it will have more specificity. Because especially when you use it as a screening method, if you use the other one which is bound to either the thyroid binding globulin or albumin, there can be a lot of things that can occur in your system, especially when you are in a critical illness or when patients get admitted for something else, which can actually have an effect on the total this one. But if you do a free T4, it is probably a little bit more specific. Now, albumin, is a negative phase reactant. So there are a lot of things that can occur, which can biochemical changes can occur, which actually helps in actually undermining the importance of the kind of thyroid hormone assays that we do. So this is the basic thing that we do. But having said that, we also sometimes assess the thyroid antibodies like thyroid peroxidase, thyroglobulin, or TSH receptor antibodies, etc., which has its own significance. Now, I earlier said that a TSH with FT4 and anti-TPO is important. I think the most important reason why it is important is because we do have conditions like subclinical hypothyroidism or subclinical hyperthyroidism and not overt hypothyroidism based on biochemical assays. So when you have a TSH which is between 5 and 10 and the T4 levels or free T4 levels within normal, you have to decide whether you need to actually just keep these patients on follow-up or do you want to actually initiate on treatment. If these patients have overt symptoms of hypothyroidism or the patients are pregnant individuals, then definitely it goes without saying that we'll have to actually initiate on treatment. But otherwise, if the anti-TPO or other antibodies are actually elevated, then it makes sense that you initially and early start the treatment. Okay. Now, there are also certain other blood tests which are not directly related to thyroid, which can have certain problems. I remember a case which was shown to me by my colleague who said the patient complains of significant pain in his lower limbs and calf. And for that, he had sent a CK levels and the total CK levels were very high. Okay, so we could not find, and a part of a routine evaluation, an LFT was also asked, where AST levels also were found to be high. So we realized that it is coming from a muscle source. And then taking a history all over again, we figured out that there could probably be a hypothyroidism. And when we checked the thyroid functions, the TSH was more than 100. Okay, so there are certain things like AST, LDH and CK being elevated, cholesterol levels including triglycerides being actually significantly high. Patients might have hyponatremia secondary to hypothyroidism. Similarly, in hyperthyroidism, you will find your ALTs as well as ALPs and bilirubin slightly on the elevated spectrum. And also sometimes PTH, non-PTH mediated hypercalcemia can also be sometimes be seen with hypercalcemia. Glycosuria and other things have been also described in hyperthyroidism. So these are certain things which you actually find in the test, which include even an anemia, sometimes a normocytic, normochromic anemia, or even a macrocytic anemia, especially if it is associated with other autoimmune conditions like vitiligo and things like that can be seen. So these clues also you should be able to pick it up when you actually order routine investigations.
Thank you, Dr. Pranav, for that extensive briefing about the investigation. Now, Sidhu, the next important thing, that you have a swelling. The next question that comes to our mind, how to evaluate that swelling. So, what are the radiological and who all require an FNAC? Do you ask for an FNAC for all swelling that is coming to you? So, can you just give us a brief?
So, sir, if you are actually seeing a patient with a thyroid swelling, first investigation will be a thyroid function test. So, biochemically, we'll see whether the patient is euthyroid or not, because only after correcting we'll be able to proceed with other management aspects. So, first is always biochemical investigation, followed by we'll be doing a ultrasound scan. So all that we need to do in a case of thyroid swelling is an ultrasound, because that is the most specific test. So ultrasound scan, we see for the nodule, the size of the nodule, the number of nodules, because sometimes we will be seeing only one single nodule outside, but there can be other small nodules on the other lobes also. So to make the diagnosis, we will see for the number of nodules and the character of the nodule as such, whether it is a hypoechoic nodule or a hyperechoic nodule. The hypoechoic being the notorious one. We'll see for whether the characteristic of the nodule, whether it is a taller than wider lesion, suggesting again it is of notorious one. Then we'll see whether there are any microcalcifications, whether the increase in vascularity. All these are suggestive of something which is little suspicious. So depending on these characteristics, there is TIRADS grading, like BIRADS for breast, PIRADS for prostate. There is a TIRADS grading for thyroid assessment in ultrasound, and there are TIRADS 1, 2, 3, 4 grading. So after doing the ultrasound, they will be grading this particular nodule which is suspicious in this TIRADS category, and depending on this TIRADS category, we'll think about taking an FNAC or not. This ultrasound will also help in identifying whether there are any other lymph nodes which is present, which is having any suspicious lymph nodes in the neck. Plus, it also helps in taking the accurate FNAC from the suspicious nodule. So, if there is any suspicion which is seen in the ultrasound, then we'll be proceeding with the ultrasound guided FNAC. And FNAC, we'll be sending it to pathology. Again, there is a grading for FNAC, which is the Bethesda classification. Again, there is class 1 to class 6. Class 1 being unsatisfactory smear sample. Class 2 is benign. 3 will be atypical features. Class 4 will be having a follicular neoplasm. 5 being suspicious of a papillary or a carcinoma. And 6 being a proven carcinoma. So, depending on the biochemical feature, the ultrasound feature, and this FNAC, we will be proceeding with the management aspect.
Any role for the nuclear scanning technicians in radiography? You routinely ask for it, or?
We don't routinely ask for nuclear scanning, sir, because only after the procedure, if the patient requires any more ablation of the thyroid, then we'll be asking for nuclear scan just to see whether there are any residual thyroid tissue left behind.
So, routinely maybe for, you can add on.
So,
because hyperthyroidism.
Yeah. So I think we prefer a technetium scintigraphy actually, because especially when patients present with hyperthyroidism, to differentiate between whether it's a Graves, which actually will have a diffuse uptake on technetium scan, whereas if thyroiditis is actually there, then obviously you will have absolutely no uptake. And other things like a cold nodule or a single hot nodule, etc., are different things. But these are the two important things for a physician's perspective, because the treatment actually makes a difference. And sometimes thyroid antibodies cannot be relied upon always. So, and this is one short thing where if it is thyroiditis induced, I think we only treat with. I'm just jumping across and just saying about treatment. We treat it only with beta blockers and not start antithyroid agents. Only in Graves' disease, when there is a diffuse uptake, we actually, along with supportive evidence of biochemical we start patients on antithyroid treatment. Yeah.
So that is maybe surgical perspective. Euthyroid swelling and FNA will be the most important. But when we have this hyperthyroidism, these three things we need to differentiate. That is a normal uptake, whether it's increased uptake or decreased uptake, or only a single area, whether it's an uptake. Definitely, and we'll be going ahead with an FNAC for those cases. So that is the only thing. Now we're coming back to madam, and one important thing that when we teach our residents is that a patient is coming back to the scenario that we'll give to them. The patient has had a recent thyroid surgery. They have come to ED with stridor. So what will be a differential diagnosis? With this background, I just wanted you to overview what are the important clinical structures and the importance of thyroid surgery and thyroid gland.
So here comes the important relations of the thyroid gland with the surrounding structures, because it produces a lot of clinical symptoms in the patient. So usually in the lobes of the thyroid gland, coming to the apex of the thyroid gland, as I already said, there is a important relation of the apex to the superior thyroid artery and to that of the external laryngeal artery, external laryngeal nerve, sorry. So during thyroidectomy or thyroid resection, so as the superior thyroid artery and the external laryngeal nerve lies in close relation up until the apex, and then it separates from each other. So it is better to ligate the artery more closer to the apex. Whereas towards the base of the thyroid gland, the inferior thyroid artery comes in relation to the recurrent laryngeal nerve. It has a variable relation, the nerve to the artery. So to avoid the artery to be severe, the nerve to be severed, the artery is usually ligated away from the base of the gland, so that the recurrent laryngeal nerve will not be involved. Now, the other structures which are related to the lobes, the surfaces, are on the superficial surface. It is related to the strap muscles of the neck, whereas the posterolateral surface is related to the contents of the carotid sheath, the internal carotid artery, internal jugular vein, and the vagus nerve in between. And the medial surface is related to we remember as 2, like 2 tubes, 2 nerves, and 2 muscles. So the 2 tubes are the trachea along with the larynx of the respiratory system. The other tubes are the pharynx along with the esophagus, and the nerves which are present are the external and the recurrent laryngeal nerve, and the muscles which are present are the inferior constrictor with that of the cricothyroid muscle. So these and there is also anastomosis between the superior thyroid arteries of both the sides onto the on the superior border of the isthmus.
Okay.
So, and another important relation is the presence of the parathyroid glands on the posterior border of the gland. So that is also of clinical importance during resection of the thyroid gland.
Do you always, Sidhu suggested, let's say, do you always resect parathyroid along with it? Or parathyroid is preserved? usually?
Parathyroid is always preserved, sir.
Okay.
We'll try. We'll not try. We'll be definitely preserving all 4 parathyroids.
Okay.
Because as ma'am was telling, it is very closely in relation to the thyroid gland. So we'll take utmost care to preserve all 4 parathyroids, because otherwise patient will be developing
Definitely
hypocalcemia post surgery.
Okay. So that's previously and all, it was like there can be accidental removal of, they will not be able to differentiate where exactly is the parathyroid. So now the surgical technique, you are able to preserve the parathyroid.
We are able to preserve the parathyroid, and if it is too much adherent to the thyroid and if it is coming out inadvertently, there is auto transplantation also which can be done.
Okay.
So that the parathyroid will regain its blood supply later, which can help the patient.
That's great. Thank you, Sidhu. So now coming back to Dr. Rose, can you just give us an overview why we have a thyroid gland? What are the function of a thyroid gland, and what is the physiological effect of the thyroid hormone?
So, coming to the physiological effects of thyroid gland, we can discuss under 3 headings.
Okay.
That is calorigenic actions, metabolic actions, and the systemic actions. So, first about the calorigenic or thermogenic actions. Actually, the oxygen, it is essential for the oxidative phosphorylation of ADP to ADP,
Okay.
ADP to ATP.
ATP.
So, thyroid hormone, it increases the basal rate of oxygen consumption, and thus it increases the basal metabolic rate.
Okay.
And thus it increases the heat production,
Okay.
and thus the body temperature.
Okay.
So that is why a patient with hyperthyroidism will be having increased BMR, then heat intolerance, and perspiration or excessive sweating.
Okay.
So that is about the calorigenic or thermogenic action. Now coming to the metabolic actions, it can be discussed on 5 headings, that is effect on carbohydrate metabolism, protein, fat, vitamin, and mucopolysaccharide.
Okay.
So coming to the carbohydrate metabolism, this thyroid hormone stimulates almost all the aspects of carbohydrate metabolism.
Okay.
That is, it increases glycolysis, gluconeogenesis, etc. Then on fat metabolism, it stimulates lipolysis.
Okay.
So the fat stores are reduced and the plasma-free fatty acids are increased.
Okay.
And whenever there is an increase in thyroid hormone, it increases the cholesterol, triglycerides, phospholipids, etc.
Okay.
That is, the thyroid hormone, what it does is that it increases the LDL receptors in the liver cells.
Okay.
So the rate of cholesterol excretion in the bile and the subsequent excretion in the feces is
Increased. Okay.
Then coming to the protein metabolism, actually in physiological amounts, this thyroid hormone is a protein anabolic hormone.
Okay.
Whereas whenever there is an excess of thyroid hormone, it is a protein catabolic hormone. So there is increase in breakdown of proteins leading to negative nitrogen balance.
Okay.
That is why it causes muscle
Weight.
weakness and creatinuria whenever
Okay.
there is increase in thyroid hormone.
Okay.
Then coming to vitamin metabolism, in the thyroid hormone, it converts beta carotene to it is the thyroid hormone that converts beta carotene to vitamin E.
Okay.
So whenever there is a deficiency of thyroid hormone, this beta carotene cannot be converted to vitamin E.
Okay.
So this carotene will get accumulated, leading to carotenemia, which
Oh.
is characterized by yellowish discoloration of skin.
Okay.
But in this, clear eye is spared.
Okay.
Okay. Then coming to the mucopolysaccharide metabolism, the thyroid hormone actually decreases the synthesis of mucopolysaccharides,
Okay.
especially the glycosaminoglycans, and it promotes the degradation
Okay.
of the mucopolysaccharides.
Mucopolysaccharides.
So in hypothyroidism, the thyroid hormone is deficient. So the synthesis as well as the degradation is affected, and the mucopolysaccharides usually it is having a gel-like consistency.
Okay.
That is why you get non-pitting edema whenever you have mixed edema or hypothyroidism.
Okay.
Okay, so that is about the metabolic actions. Now coming to the systemic actions. So first we will discuss on the growth and development.
Development.
That is The thyroid hormone, it is essential for the normal body growth and development.
Okay.
That is, it increases the protein and enzyme synthesis, as I told. Then also it is increases the production of growth hormone and somatomedin. So it is essential for the overall normal body growth and development. Then coming to the important system, that is CNS. That is the thyroid hormone. It's essential for the normal development of a central nervous system, especially during infancy and childhood. That is, it is essential for the growth of cerebral cortex, cerebellar cortex, then for the proliferation of axons, dendrites, then for the myelination.
Okay.
So that is why, suppose if you have a thyroid deficiency during infancy, it can lead to irreversible mental retardation. That is why it should be early detected and corrected as soon as possible.
Okay.
So that is about the CNS. Then coming to the cardiovascular system, the thyroid hormone actually, it increases the blood volume, then it increases the blood flow, cardiac output, then it increases the heart rate. So heart rate, it is important. That is, the thyroid hormone actually, it increases the receptors in the nodal tissue.
Okay.
And also it increases the sensitivity to catecholamines.
Okay.
So that is why whenever you have hyperthyroidism, you get tachycardia, even during rest or sleep. So that's it. Then coming to the effect of thyroid hormone on the blood pressure, because of the increase in heart rate and cardiac output, the systolic blood pressure will be increased. And because of the calorogenic action, because of that, there will be vasodilatation, decreased peripheral resistance, and thereby the diastolic blood pressure will be decreased. So the systolic blood pressure is high and diastolic blood pressure is low. So the pulse pressure will be widened. So in hyperthyroidism, you get widened pulse pressure. Then coming to the GIT, it increases the rate of secretion and motility. So in hyperthyroidism, you get diarrhea, and in hypo, you get constipation.
Okay.
Then coming to the effect on skeletal muscle, actually a slight increase in the thyroid hormone will make the muscle to react with vigor. So that is why in hyperthyroidism, you get exaggerated tendon reflexes.
Okay.
Whereas in hypothyroidism, the muscle will react only slowly upon contraction. So you get delayed tendon reflexes. And also in hyperthyroidism, you get tremors at the rate of about 10 to 15 per second. Actually, that is due to the overreactivity of the synapses, neuronal synapses. Then an important point what I need to stress is the action on the eye. That is, in hyperthyroidism, you get exophthalmos. That is the edematous swelling of the retroorbital tissues. That is nothing but the proliferation of the connective tissues within the walls of the orbit. So there is a recent theory that is in that it tells that in the orbit there is pre-adipocyte fibroblast, and on these fibroblasts you have TSH receptors, and the TSI of the thyroid stimulating immunoglobulin, it will bind to these receptors and they form cytokines.
Okay.
That is the reason for the inflammation and edema.
Okay.
So that is in nutshell
regarding the.
Actually, it is a very wide one.
Wide,
so I have concised and.
Because the question was why we need a thyroid gland, and it was elaborately discussed. With this background, now it is more relevant. We'll just go ahead with the clinical features of hypo and hypothyroidism.
I don't think I need to say anything more. I think because Madam has said everything actually in detail with the actual mechanism of why each of these things are there. But when we look at it as in a clinical perspective, I think one thing you need to actually look at is a few clinical pearls that I'll give, because all those things have already been mentioned. In hyperthyroidism, whenever somebody comes and tells you regarding weight loss, you always ask one history of whether it is with preserved appetite or not. Usually, a weight loss with preserved appetite is most probably an endocrine cause, and when it's obvious, I think it is definitely hyperthyroidism. So that is something that is there. But if any standard medical textbooks you take, I think it's the different clinical features have been divided into very common ones, less common ones, and rarer ones. Okay, common ones and less common ones have already been covered, but certain things that I would like to say in women, actually how the menstrual cycles, okay, it gets affected. In hyperthyroidism, it can cause amenorrhea or even actually oligomenorrhea, and whereas in hypothyroidism you get menorrhagia per se. Okay, and the propensity to develop atrial fibrillation, definitely, which is an important clinical entity for a physician. It is actually much more with definitely hyperthyroidism, and sinus bradycardia, which is actually significantly more with hypothyroidism. Certain other things, which some of which have already mentioned regarding the high CK and things like that. Similarly, in hyperthyroidism, you will get sometimes proximal myopathy, and the mucopolysaccharide aspect has already been mentioned. You will get something called as a pretibial myxedema in hyperthyroidism, whereas a non-pitting kind of an edema in a myxedema coma or myxedema crisis per se. So the classical thyroid, hypothyroid facies is also important, where there is significant coarseness of features, there is dry and textureless hair, and sometimes, again, that has been the yellowish discoloration that are there, which I actually understood much better after listening to her regarding the beta carotene and things like that. So I feel the major clinical features can be always, and this is something that you have to refer your textbooks and actually find out, because it's very important. Because now, earlier I think thyroid was a chapter which was predominantly for the surgeons in the old curriculum, but now I think if you look at the new topics in medicine, one topic is exclusively for thyroid based disorders, and I think it is very important that this can even be a clinical case, which earlier used to be under only surgery. We could also be actually giving you a clinical case in for discussion, because common cases are what actually we are going to keep from now onwards.
Hair loss.
Yeah, hair loss, alopecia. There are n number of things which you can actually think about. It might be a lot of things would be repetition, so I didn't want to actually say everything again.
So even hypo and hypothyroidism both can cause this hair loss.
Yeah, both
can melanosis. So these are all the common things that what we keep in your mind. So to summarize the clinical features, in hypothyroidism, maybe everything can be slowed down. Something like that we can keep that, maybe like constipation, cold intolerance, decrease in the heart rate, edema, the BMI, the basal metabolic rate is coming down, and when you go to the weight gain also. When you go to the hypothyroidism, the common symptoms that we can remember is the weight loss, increase in the appetite, and all those things. We can keep those things in your mind. Sidhu, now the most important question that I wanted is that the previously whenever we get a question, we used to get a question like thyroid stone. So that was the very common general surgery perspective question. So how will you manage a thyroid storm if at all you are admitted or seen a patient? Definitely it is a multidisciplinary approach. You need your physician's help as well as the surgeon's help. So whether you straight away take into the surgery, or what are the things that you will do before when you have a patient with thyroid storm, and both of you can complement each other for this aspect as.
So first of all, as I mentioned before, we never take a patient without making the patient euthyroid for a surgery.
Okay.
Because thyroid storm will be present if we are taking a hyperthyroid patient without controlling the patient adequately before surgery. And thyroid storm as such is not only surgical, it can be a medical thyroid storm also. So in case of patient is having hyperthyroidism, and if it is not controlled, patient getting any infection, any sort of stress, the patient can go for thyroid storm. One other surgical complication will be if you are taking a non-unprepared patient for surgery, intraoperatively patient can go on for thyroid storm. So the anesthetist will be the first person to notice the changes which will be happening in the body. So the patient can get tachycardia, increase in body temperature, and other features will be there. So initially we will be giving beta blockers, propranolol IV intravenous propranolol will be given to control the heart rate and the peripheral conversion, everything. Then you give the cooling blankets and for the hyperthermia management. Then you will be giving anti-thyroid medication. Carbimazole is not available as a intravenous, so we give propylthiouracil instead. So propylthiouracil will be given. Diazepam will be given for relaxation purpose. So basically it will be managed along with the anesthetist in such a scenario.
Okay. Dr. Vinay, just an overview of each steps we need to steroids, the role of steroids.
Steroids, I mean, in a situation where thyroid storm is there, I think hydrocortisone 100 mg Q8 hourly to 6 hourly definitely needs to be added. That is the only extra thing that I want to add to that. But otherwise, the algorithm is the same. I think first is definitely the beta blocker therapy, and then comes the anti-thyroid. Like he mentioned, the carbimazole and methimazole is actually not available. So I think definitely the one that is preferred is propyl thiouracil, and then I think the triggers is much more important actually. How to prevent that trigger, to make the patient clinically euthyroid before actually doing any procedures on a thyroid. I think not just the surgical aspect, even actually an FNAC also I feel can actually trigger if not properly ensure that the patient is actually euthyroid. Treatment, you know that even in the best of the centers, sometimes we can actually have problems and mortalities if it is not actually detected very early, because it can cause significant other problems, which includes a higher output cardiac failure. Patient can go into AF and things like that, and significant hypothermia related complications. So all those things, unless and until you have a good critical care setup, it might be difficult to actually manage. Yeah.
And one more just thing, when we learn these things is that pregnancy we avoid methimazole, and propyl thiouracil is the drug for PP for pregnancy. So that was the previous concept. Now if the patient is on low dose of carbimazole, it is accepted to some extent, or you still prefer to put the patient on propyl thiouracil? Prefer to put on propyl thiouracil. So I think if the patient is something like 10 mg, you will make it to 100 mg of propyl thiouracil. That will be the usual conversion factor into 10 times of what the patient was taking carbimazole. So with this in background, the next question will be, the most common what we see is hypo and hypothyroidism. Previously it was hypothyroidism. Now we are seeing a lot of hypothyroidism also. So sometimes the patient initially goes for hypothyroidism, as you have already mentioned, they will come to hypothyroidism. So how will we manage this hypothyroidism? It's basically more of a medical management.
Yeah. So hypothyroidism management, I think I would like to divide it into a patient which is normal versus in certain special scenarios, and then I think I'll touch upon mixed edema coma also. I think so. In a normal individual, I think to start off 1.65 microgram per kg can be started. This roughly comes to somewhere around, for a 70 kg individual, is about 100 microgram. Now a lot of strategies are there. Some people actually started with 50 microgram, increased it, reassess after 3 weeks, and then go on to about 100 to 125, whatever the strength is. But most of the newer strategies says that if actually patient is otherwise well off, you can even start off with 100 microgram and then titrate accordingly. But when will you check the TSH after starting? That is another important thing. I think TSH should be checked minimally after 6 weeks. I think probably 6 weeks to 8 weeks would be the right time to actually reassess a thyroid function. And what do you want to achieve? We want to achieve a TSH which is actually within normal range. Within normal range also, I would actually, because the normal TSH range is between about 0.5 to 5 in most of the laboratories, I would like to keep it between 2 and 3. Or FT4 just above or upper limit of normal. But usually when I actually follow up patients, because of the cost constraints and things like that, I usually just do TSH and try to keep it between 2 and 3 and see whether the symptoms have resolved. Now symptom resolution also actually takes time. The weight gain and all the other the basal metabolic rate related functions can actually slowly, come down actually as early as about a third week per se. But certain things can actually be much prolonged, like whatever has already happened to the skin, the coarseness and things like that, it can take a long time. And sometimes as a very rare manifestations, patients can have serositis, like pleural effusion, ascites, as well as pericardial effusion. I had a patient who took about 9 months for the pericardial effusions to actually completely resolve. Never required a pericardiocentesis, never went into a tamponade stage, but actually significant, this one on the X-ray, and repeated echoes had to be done till actually patient actually became completely dry. So that is something that we have to understand regarding a normal scenario. But there are certain scenarios where actually special groups are there, like in an elderly individual. I mean, you have to understand that the clearance is actually less. So you have to reduce the dose and you cannot give a higher dose. Similarly, patients with underlying heart diseases, ischemic heart diseases, what will happen is if you suddenly increase the metabolic rate, angina and other ischemias and infarctions can occur, and this can be detrimental for the patient. So in such patients, we actually even started as low as about 12.5, slowly titrate it up every 1 or 2 weeks based on this one, and then reach the basic the required dose. So this is something that we usually do in regular population. Another important population definitely is pregnant women. So you whatever dose that is going on, I think regarding the hyperthyroidism, Dr. Sri Krishna has already said. Here also, I think an increase of 30 to 50% is really required if its patient is already known hypothyroid. Where in the first trimester, obviously the dose has to be much more, and then there are algorithms and actually trimester-related dosing charts available where you'll have to check and adjust it accordingly. And if whenever you require help, I think obviously going to a subspecialist where endocrinology consultation has to be given to actually make sure that this is going on adequate. Okay, so that is important. Now coming to the other spectrum of the emergency, that is mixed edema coma. Again, it is a very important emergency that is there, and most of the times actually we can lose patients if it is not even detected properly. So when it's detected, you know the features associated with that patient will have hypothermia. And here also I think it's very important that we actually start steroids. The reason is that unless proved otherwise, we would like to consider it as a secondary hypothyroidism and treat as early as possible. Steroids are very important. So like 100 mg Q8 hourly to 6 hourly can be given, and the other treatment like rewarming and making sure that the patient does not, because the sensorium is going to be low, does not aspirate, and other basic measures of antibiotics and other things like that have to be given. But the most important thing is how to give the thyroid. Now IV preparations, unfortunately, in our scenario, we do not have it. So what we usually do, especially because the patient is significantly in a comatose kind of a stage, we put a Ryle's tube and give the higher dose of the medicine itself. We understand that the absorption is going to be very less. That is why we go up. I mean, if you are looking at something like 200, then you give 200 and then see how it responds. Response will be low because the absorption is going to be less. But that is the best we can actually do at our scenario. Yeah, for mixed edema coma. And then as soon as the patient, because hyponatremia is likely to be there, so that also might require correction. And these aspects have to be looked at. And again, like I mentioned about thyroid storm, it has to be actually in a critical care set. Yeah, thank you.
And just one more question. Do you start looking at the TSH? Somebody is coming with your report like my TSH is 10. Do we start treatment for them or we'll wait for them?
So I mentioned this about subclinical hypothyroidism when I discussed. So I think the overt symptoms, if it is there, or patient belonging to a special class like pregnant women, definitely we have to start. Otherwise, a useful test you can actually add on is checking a anti-TPO. If the anti-TPO is elevated, you eventually know that this patient is likely to go into hypothyroidism. So the study says that it is better to start earlier. But otherwise, between 5 to 10, and some older textbook says 5 to 20, where the subclinical hypothyroid range, it is usually better to wait and watch and to see repeat TSH and FT4 levels after about 6 weeks. Yeah.
Okay, thank you. And so that we have elaborately regarding the pharmacological aspects, and coming to the surgeon. So who all requires surgery? So which all patients you decide, okay, this patient requires a surgery, and what you prefer, whether it's a total thyroidectomy or a subtotal?
Not all thyroid swellings require surgery. So again, it depends on like we have already discussed regarding the Bethesda classification for the pathology classification. So depending on the Bethesda classification, if there is a atypia which is category 3, or if there is a follicular neoplasm, and so 3 and above we will be suggesting for surgery. And one other indication for surgery is the cosmetic indication, even a category 2 benign thyroid swelling. But if the swelling is very big, the patient doesn't want to have such a big swelling, then again we'll proceed with surgical management. Or if the swelling is going retrosternally, which might compress the vessels, great vessels. So then again we'll proceed with surgical management. So these are the indications for surgical management in a thyroid swelling or a thyroid nodule. So, and coming to the surgical aspect of it, unless it is a solitary nodule of a single lobe, then we can suggest the patient for the option of a hemithyroidectomy. Hemithyroidectomy is removal of one lobe along with the isthmus, preserving the other lobe. Okay, so in a hemithyroidectomy, if the surgeon is proceeding with a hemithyroidectomy, then the patient should be counseled that if in case the histopathology report, the final biopsy report is coming as a carcinoma, then within the next 2 weeks, the patient should be undergoing a total thyroidectomy. If the patient is agreeing to that particular plan, then it is okay and it is textbook recommended to proceed with a hemithyroidectomy. If not, the patient is telling, I'm not planning for a second surgery, I don't want my thyroid gland, you can remove it. So in such a scenario, you can proceed with a total thyroidectomy, but always the complications of total thyroidectomy will be explained to the patient. So I'll proceed with the total thyroidectomy. So again, coming to the complications, I'll be telling it like we explained it to the patient. So there will be a scar, a collar crease scar, like a crease in the neck. There will be a scar which will be seen, which will be almost around 10 centimeters. And post surgery, the patient, like we discussed before, the parathyroid blood supply can get affected. So the patient can develop a postoperative hypocalcemia. That is another complication. Then we forgot to mention regarding the most important thing, which is the recurrent laryngeal nerve, which runs in the tracheoesophageal groove. If there is an injury to the recurrent laryngeal nerve, the quality of voice will be changed. So prior to taking up a patient for surgery, we always send the patient to the ENT to check for to do indirect laryngoscopy to check for the vocal cord assessment. Because prior to surgery, medico-legal aspect, we need to know that the vocal cord is working properly or not. So recurrent laryngeal nerve is of great importance when coming to thyroid surgery. And last, we'll tell the patient regarding the lifelong thyroxine supplementation.
Thank you, Dr. Sidhu. So, thank you all for that brief overview. I think we have almost covered everything. Some special situations only, that's what we have not, maybe nuclear, ablation and all those things we haven't covered, like Lugol's iodine, the nuclear therapy, which is not to the limit of an undergraduate student. So whatever is basically required for an undergraduate student, started with an anatomy, physiology, the important questions. And from medicine perspective, hypo and hypothyroidism are very commonly asked questions, and we can have clinical scenarios being given, and they can have a long case also. And definitely surgery, thyroid swelling is going to become as a long case for you. So if the patient is there, definitely it is going to come. And theory aspects also, we have almost whatever we have covered is all essay questions, and it can come as a short note. So once again, thank each one of you for attending this vertical integration. Thank you all.